The diagnosis part is already complete and the surgical part is already complete. So I think nobody will be interested in the medical management because it's the least important part. We need to diagnose and we need to do surgery. So nobody wants to treat. But let me go ahead with my presentation. It's the role of medical management in PACD from pilocarpine to PGA. So I'll start with pilocarpine. So this has been the scenario for the past 6 months to a year, where every site you go to, be it 1mg, be it PharmEasy, you see pilocarpine is sold out or out of stock, or you go to the medical shops, they are not there, patients are calling you. However, the things have changed drastically over the past few months. Pilocar is again going to be available, and certain newer drugs like Pilokite from Kamla Life Sciences is already available, at least in centers in Calcutta. So things are again looking up. Now, why do we need a drug like pilocarpine? The answer to that is myotics are the only medication which have a mechanical effect on the conventional outflow pathway. So they are the only drugs which have a mechanical effect. Now, why is that important? So I want to quote a few studies which have been done on genomics as well as ultra microscopic studies which state the following. Number one, the aqueous humor supplies antioxidants, growth factors and nutrients to the trabecular meshwork outflow tissues. A. B. Drugs which suppress aqueous humor production and or enhance uveoscleral outflow, which is basically all the other drugs, they decrease the aqueous humor supply to the outflow tissues. So what does that do? It causes nutrient deprivation to these tissues in the long run, and so greater than normal degradation of the trabecular meshwork occurs, and you are causing more damage and more risk over time. So I just wanted to throw in some controversy. Rest is up to you. So basically all the drugs that we are using to treat open angle and angle closure glaucoma probably in the long run may be doing greater harm than good. Therefore, we definitely need drugs like myotics which have no effect on the reduction of the aqueous humor or the uveoscleral outflow. However, there are certain situations where we should not be using pilocarpine, like in patients with phakic IOL. So this was a particular study where the patient had a +7 diopters in the right eye, +7.1 in the left eye. Post phakic IOL, the surgeon gave pilocarpine to accelerate the recovery, and that caused a phakic IOL lenticular touch, which caused cataractous changes. So probably in these cases, do not use pilocarpine because this vault is going to reduce. You need this vault to prevent the contact between the phakic IOL and the lens. Now, there is a problem with pilocarpine, and the studies done on aging rhesus monkeys. So there are no human studies as such, but there are umpteen number of studies in rhesus monkeys which show that the pilocarpine induced responses of the ciliary muscle and outflow facility, they decline with age. So that may explain the reason why some of your patients, they were on pilocarpine or Timolol and pilocarpine, they were doing pretty well, and after 10 years, suddenly now the IOP starts to rise. So these studies can probably explain, and like I said, it's not one, there are a number of studies which state that the contractile response to pilocarpine diminishes with age at a rate which is similar to that of accommodative decline. So maybe you're treating the patient, you are getting a good response, but over time, you'll see that the response wanes off. So this is to be kept in mind. I want to shift on to the next group of drugs, the ROCK inhibitors. Now, why did I put the ROCK inhibitors after pilocarpine? Like I mentioned, pilocarpines, they have a mechanical effect on the conventional outflow, whereas ROCK inhibitors, they increase the conventional outflow through the trabecular meshwork and the scleral spur. However, the mechanism in which they do it is different. They alter cell contraction, cell motility, they cause cytoskeletal rearrangement, cell adhesion, remodeling of cell-to-cell contact, alters the episcleral venous pressure, etc. So ROCK inhibitors also are the only drugs which act on the conventional outflow pathway. So all the other drugs, they have no effect on the conventional aqueous humor outflow. So probably this is a niche product and should be kept in mind. Now there's a problem with both ripasudil and netasudil. That is, all the studies are on open angle glaucoma and ocular hypertension. So there are no studies on angle closure glaucoma. However, we have been using it since pilocarpine was not available. I shifted a lot of my patients to ripasudil and I've got pretty good results. So probably there is definitely some role. And some of these studies, like this particular one, it says that there are some pleiotropic effects of ripasudil. Pleiotropic effect means it's not the main effect, but certain other associated effects like neuroprotection, increased ocular blood flow, anti-inflammation, anti-scarring, decreased macular thickness in eyes with the DME, and corneal endothelial cell effects. Obviously, the corneal endothelial cell effects have been very well publicized. So in angle closure patients where the chambers are shallow, probably post-surgically also, ripasudil or nirasudil may be used. Also, there are some interesting studies which conclude that ripasudil can be a trabeculoplasty outcome marker. That is, presence of a ripasudil effective eye appears to significantly predict the success of trabeculoplasty. Now, trabeculoplasty is usually done in open angle patients. However, efficacy of SLT in primary angle closure glaucoma has been shown in certain studies. So I'm just playing the devil's advocate. There are no studies on angle closure, but probably it may have a role. Also, ripasudil has been proven to be a trabeculectomy outcome marker. Again, in open angle glaucoma cases, but playing the devil's advocate, maybe it has a role in angle closure patients also. This particular study showed that ripasudil has got a very good effect on uveitic glaucoma patients. So there is a greater than 60% reduction in the number of patients, 40 to 60% reduction in the number of patients, 20 to 40% reduction. That is overall 70% reduction of IOP in uveitic glaucoma patients. So uveitic glaucoma patients have a lot of pus, they have a lot of pigments. So probably ripasudil will have some effect on angle closure glaucoma patients also. Coming to brimonidine. Now, brimonidine decreases the aqueous humor production, facilitates UV scleral outflow. And there's something very interesting which happens with brimonidine. It has a miotic effect. Therefore, it is used to prevent glares and halos and reduce visual aberrations after refractive surgery. So, it does cause miosis, but does it cause changes in the angle? And this was shown by a study by the Corantes group, which showed that even though brimonidine has a miotic trend, it has no significant effect on the anterior chamber angle in patients with narrow angles. However, do we need to use brimonidine? Yes, Dr. Ganesha has already mentioned pre-procedure before a PI, post-procedure to prevent the IOP spike, we do need brimonidine in angle closure glaucoma patient. Coming to brinzolamide, how many of us use brinzolamide in angle closure patients? A show of hands. Do we use brinzolamide? No one uses brinzolamide. We all do, all of us do. But there are these studies by Chen et al. Which show that in the acute phase, brinzolamide did not improve the effectiveness of the sequential treatment. Also, if you look at the summary of product characteristics or all the literature which is supplied with the drops, they say brinzolamide has not been studied in patients with narrow angle glaucoma and its use is not recommended in these patients. But don't follow it, we all use it and therefore it gives pretty good results. However, it's not backed with evidence. We do find that there are excellent results. Coming to dorzolamide, again, dorzolamide has been shown not to have excellent effects because latanoprost monotherapy, as was shown in this particular study by Sakai et al., was more effective than unfixed combination of timolol and dorzolamide. So probably it should be used but as a second line because prostaglandins have emerged as the first line. Timolol, we definitely use timolol, and according to some studies, timolol has more effect in post-LPI or post-surgery. And timolol plus pilo is better than timolol alone. However, again, latanoprost was more effective than timolol twice daily. I will end with prostaglandin analogs which have now emerged as the first line management in any form of angle closure. So the meta-analysis studies show that latano, travo, bimato all provide significant IOP lowering efficacy in eyes with angle closure. The efficacy is not affected by degree of angle narrowing or extent of pus. There are multiple studies on this. Both latano and bimato significantly reduced IOP in CACG patients who were inadequately treated with LPI. That is, post LPI it is very effective. And in cases with 360 pus, is it effective? The answer to that is yes. There was significant reduction in IOP in CACG patients even with 360 degree of pus. So in an acute attack, probably the drugs we need to use are beta blockers, alpha agonist and PGAs. What is to be looked into, I'm not mentioning the newer agents, but probably the miotic which act only on the pupillary sphincter but not on the ciliary muscle needs to be looked into. Brimonidine in angle closure needs to be studied, and how PGA works in fully closed angles needs to be studied. Thank you so much.
There is going to be a thank you, ARIJIT, for a very comprehensive, informative presentation as usual.